Hello, everyone, and welcome once again to those of you who are just joining us. This is our second installment this term of Nursing Health Services and Policy Research Colloquium. And we're very pleased and grateful to have Dr. Adrienne Martinez Hollingsworth here with us. The format today will be similar to our other presentations, where we'll have a period for presentation, and that will be followed by time for questions and answers. And I will direct your attention to the chat, where Dr. Martinez Hollingsworth has included her email address. So thank you for doing that, and has invited you to reach out after the presentation if you wish. So I would like to introduce our speaker today with a short bio. Dr. Adrienne Martinez Hollingsworth is a registered nurse and a graduate of the CDU Master of Science in Nursing program. She received her PhD from the School of Nursing at UCLA and is in her second year of postdoctoral training at the National Clinician Scholars Program. Adrienne is currently leading a multi-phase mixed method study exploring the impact of provider burnout on diabetes care delivery in the safety net. As a clinician, Adrienne has practiced for 13 years in acute psychiatric settings among low-income, uninsured, and undocumented populations, including justice-involved individuals with severe mental illness. As an administrator, Adrienne served as the national nurse lead for Oscar Insurance and the nursing supervisor at the Children's Hospital of Orange County. Adrienne is the founding board chair of the CDU Alumni Association, currently serves as a co-chair of the Latino Special Interest Group for the Western Institute of Nursing, and is the creator of Theory Generator Playground, a Latino student research collective seeking to diversify the healthcare pipeline. Welcome, Dr. Martinez Hollingsworth, and thank you for your presentation. I'll turn it over to you.
Yay, thank you. Feel free to call me Adrienne. Hi, everybody. Good morning. I'm going to start sharing my screen, but I do want to warn you that I'm not going to be able to see what you put into the chat once I start fully sharing it. So I would love for people to just, feel free to interrupt me with questions as we're going. I've given this presentation 2 times now, one to, for theoretical sampling to kind of verify the data, and then once to just a large group of clinicians, and the feedback's really helpful. So go ahead and interrupt me along the way, and I'll make sure we have time for questions at the end. Okay. So as I said in a recent presentation, this is somewhat of a misnomer because I'm not going to teach you how to overcome burnout in the safety net. I wish I could, but we're still just trying to tease out this topic. But I am going to talk to you about how mission-driven ethos is really leveraged into outpatient settings. And this talk reflecting findings from a study involving administrators, but if you're not an administrator, it may at least help you kind of position yourself. So you've already heard all the blah, blah about who I am, but I'm always happy to connect with people later if you're thinking about doing a PhD, especially, and you're kind of uncertain if you're a clinician, or if you just want to get involved in research projects to kind of augment your clinical experience. So the purpose of this study, I'm going to kind of shrink myself down here so I can see the screen, is really, or actually the purpose of this talk was just to discuss findings from phase 1 of the study that was just described to you. So I'm exploring organizational level factors impacting burnout in safety net primary care clinics. I care about clinician burnout, but my main motivation is that I care a lot about care delivery in these historically under-resourced settings, and I want to make sure that we can do what we can to support it. I'm going to be sharing some practical lessons from this data. So the objectives are to just review these factors that impact burnout that have kind of emerged through these conversations, and describe some categories that appear to change the experience, either worsen it or mitigate it, and then really discuss some practical lessons. And this is kind of a key issue right now. The way I've heard it described is the house is clearly on fire, right? In a hospital setting, in the outpatient setting, during a pandemic, the house is on fire. And we don't necessarily need to know how hot it is at this point. We mostly need people to start bailing. So I am going to talk a little bit about, what can we do now? So quick self-survey. And normally I put up a poll. I'm not doing that here because I don't know how well everyone knows each other, but during the past month, have you felt burned out from your work? So just kind of take a second and consider that and think about a period of a month and what that encompasses. So normally when I put up a poll here, would anybody like to guess the percentage of people that say yes? Is it like 40%? Is it like 50%? Is it 80%? I think in reality, oh, I'm sorry, go ahead.
Yeah, I'd say greater than 75%.
That's actually an excellent guess. When I've done this poll, and I've done it several times in different settings, the consistent number is between 75 and 80%. And in a larger sense, if you were to look at the national data, what's coming out actually just recently got published by the Wellbeing Index, we're looking at that range. We're looking at like 75%, a little under that, right? So actually it's like 65 to 75. So what is it about all of us, right, that we're going through this? But what is it about people who are coming to these sorts of seminars and getting together who appear to be like a little bit more burned out than the national average? So there's something about us, basically. Again, I didn't take this measure here with this group, but when you think about a month, you're not talking about having a bad day. You're talking about your actual kind of daily environment grinding on you a little bit. So I'm sure it is no surprise to anyone that burnout is a critical challenge in healthcare. And I like to point out that it shouldn't be a surprise, but I started my PhD looking at care delivery of diabetes, just kind of long-term diabetes care in these safety net clinics. And I was working with older Latina women. And it turned out that a lot of, I'm sorry, my dog is trying to get out, excuse me. Don't you love working from home? I don't know what he's gonna do when we go back. So in these kind of long-term care experiences, the patients I was talking to were experiencing some really depersonalized care that was lacking empathy. And I decided that I wanted to tease that out. Some of the things that were said to them by providers was kind of shocking. I was like, no way. How could somebody who's gone to medical school, gone through all their residencies and trainings and like decided to work in this setting say things this hurtful, right? And so it allowed me to start looking at depersonalization, right? When you're giving this care that's lacking empathy, which led me to burnout. But at the time when I started pitching this research topic, what I was told, and this was about 2 years ago, was there is no funding for this. There's no interest in burnout. There's no funding for this. There's only one lab out of Stanford that's doing any of this work. And I will tell you that things certainly have changed. Since that time, in the last 2 years, a week doesn't go by where I'm not finding some new funding opportunity or I'm being asked to speak at things, because we're recognizing this is a critical challenge and it's a timely challenge. We know that it impacts the quality of care that we deliver and provider health, especially in terms of depression and suicide. At the organizational level, we know that it reduces performance, which equals, financial impact. It increases turnover, which matters because it costs about $1 million to replace a physician if they leave, in terms of recruitment and onboarding costs. And for registered nurses, it's about $80,000, and that's not accounting for specialties. And it's associated with medical errors, right? So not only are we talking about more cost, but we're talking about changes in utilization patterns. In terms of providers, like I said, it's associated with physical and mental illness, very serious. Death by suicide, we're looking at right now about 1 per day nationally from physicians, which we know is a population that we care a lot about, but also that we cannot afford to lose any because of our crisis right now in terms of staffing. For patients, interestingly, it lowers their participation. They can tell when that empathy is lacking, and they perceive the kind of behaviors that we start to do when we're feeling burned out, like making more referrals or trying to kind of, hand over some things like medical education to other groups. They see that as low value care. And because they perceive it as low value care, again, they're less adherent. So I like to look at federally qualified health centers because these are considered high risk areas for burnout, because the patients are managing social needs. that reflect a historical legacy of medical and economic and educational disenfranchisement, right? So when you have a patient come in, you're often dealing with these kind of larger societal structural issues that are impacting how healthy they are. And you as a provider are being asked to manage it kind of at the point of care in a way that we're not really qualified to do. And then of course there's chronic understaffing in these settings, because if I were to ask you to tell me one thing you've heard about working in these settings, I don't know if anybody does, what have you heard about whether you get paid well in community clinics in low income areas? Has anybody heard anything? I'm not going to put you too much on the spot. But
I don't think it's a high pay area, no. I think
yeah,
it's more of a passion serving area that drives people into these settings, is my understanding.
Wow. So I totally didn't need to do this study. I could have just talked to you. But yeah, absolutely. It is not a high paid area. And there appears to be this expectation that people are there because they are somehow ethos driven in a way that alleviates the facility from having to really pay necessarily even scale, right? And I saw this when I worked in children's hospitals too. There was this sense of you know, part of it is you're doing it for the cause, and that's sometimes directly related to the compensation they would get compared to other settings. So unfortunately, as I said, I've studied well-being and burnout for about 2 years now across a variety of places. I think I told you Stanford was the only one really doing anything big. They had taken Tate Shanafelt from Mayo, and so I went up to Stanford and I worked there for a while, and I you know, reworked some conceptual models, and I'm back at UCLA and doing like some community stuff. And basically what I've found is that there is no cure-all. I wish I could hand you some panacea, and I just can't. But what you may be familiar with as a layperson, if you're not working in this space, is all of this kind of messaging that started to really become a big part of at least my Facebook feed, right? Because the algorithms are saying that, like, I'm a provider, I study burnout, right? So I'm getting stuff that's like, you have to have better work-life balance. You should try this mindfulness app. You should get more exercise. You should go hang out with friends, or you should get out into nature. So there isn't a cure-all, but there is a lot of gaslighting. And this is something that I think we need to confront head on, especially in terms of provider depression and suicide, because the impression that you get from all of this data is that you should be doing something to make this manageable for yourself. And I think we all know, those of us who work in health systems, that you know, this scenario is not individually focused. This is about systems. But it took me a while to get there. So when I was at Stanford, we did this MedX burnout work group where we took, MedX is Medicine X is this big annual conference where they get generally residents who do a one-year fellowship, and they are partnered with a patient, and you come up with some sort of capstone project. So I had done that training in the past when I was in my PhD, and I was visiting to do this work. And that put me in this space where providers and patients were talking about burnout, right? So we're working to develop this community-derived definition, because burnout's all over the place. But that actually wasn't the most important part of my experience. The most important part was the offline, which of course we're all missing this year, the after, you know, after conference drinks and coffees where you actually get the real stuff. What I was getting was a lot of these offline comments that were making me think something else was happening here. So here's just some of the quotes that I got from that time. It's like a bad boyfriend telling you one thing and reality is something else. Like, it's your fault, but it's the system's fault. The word gaslighting was used quite a bit. I got through medical school. I know how to shop for my own groceries, but too many patients is too many patients. This was, at the time that I was there, they were increasing the daily caseload, but at the same time, they had decided to order all of the physicians this like Blue Apron delivery service. I think that's what it's called. And, you know, I think the intention was good. The intention was, people are busy. Wouldn't it be nice if they got home and there was like a meal prep that they could do and they wouldn't have to shop? But the way it came off was, you know, you're doing this to make me not so angry about the fact that you've doubled what my workload is. I'm really sorry. My dog is going crazy for no real reason. Anyway, so yeah, so that was the idea, was some people really wanted to leave. This gesture from the organization was almost the final straw for some of these providers. And then the other thing was, they were having these kind of well-being retreats in these beautiful places, right? Because up in Palo Alto, you've got some really nice places up there. But people were saying, I don't want to spend my hard-earned weekend at a retreat. Don't I give enough of my time, right? So I started hearing these comments, and it made me decide to look at the systemic level, at some of these issues that were driving burnout that we're not really focusing on. So that led to the study that you're about to hear right now. And again, as you know, my wonderful host mentioned earlier, this is a multi-phase mixed method study, right? So this is just the first part to really kind of get some sensitizing data and make sure that we're looking at the right things when we're selecting variables, kind of later on where we're doing a lot of electronic health record work. But this study looked at administrator views on burnout and the safety net. And the idea was I wanted to determine what organizational factors impact burnout in this setting. And FQHCs are federally qualified health centers. So these serve low income, under-resourced, traditionally racial ethnic minorities. They can be urban, densely urban, or they can be rural. And then are these factors represented in our current measures of burnout? But the main thing was I wanted to know, because this study crossed the pandemic, what strategies are working right now, because the house is on fire. Right? So if these organizations were going to agree to work with me, I wanted to make sure that I had something to offer them, because nobody has any extra time. And it takes time to sit with me for an hour to 2 hours, at least once, maybe twice, and just kind of talk about these issues with no promise of any sort of resolution. So I continue to have these interviews, even though I've really stopped kind of technically gathering data, because it seems to be important for people to be able to, you know, offer something from everything that they're going through, even if they're able to give me just kind of a little window into their reality. So there is some emergent data, and I have updated these categorical findings since I first ended this study, which was about 3 months ago. But there we are. So if you've seen this presentation before, it may look a little different. I did start collecting data in September of 2019, and I stopped with the formal interviews November 2020. But as I said, I did another one even last week, administrators that continued to reach out to me. This is a qualitative thematic analysis. I looked at federally qualified center clinical administrators, and these were registered nurses, licensed clinical social workers, PsyDs, physicians. These were all people who held like a senior position and or chief medical officer position. The reason was they were the people who could actually make some decisions. So formally, I worked with 14 individuals and did 18 interviews with those individuals, which included some theoretical sampling. This was all in Southern California here. This was convenient sampling because we had these sites already affiliated with our larger burnout study, and some snowball sampling, just because, this is a small world, actually. I'm sure most of us on this call know that. And when people were able to talk about their burnout, they were like, oh, you know who you should also talk to is my friend who's at this clinic, or this organization right over here. And it turned out that most of these places were affiliated with the local community clinic association. So actually recruitment wasn't an issue, but I will tell you that I had people who qualified and had every good intention of participating, but would subsequently tell me, I just don't have time for this. Like, I wish I could do it, but I can't. I also had a very small portion of people who were concerned about doing the interviews. And I'm going to tell you about that later on in the findings, because there's kind of interesting stuff. Because you could ask yourself, why would you not want to know whether or not your, what you're doing is reflective of the standard practice, whether or not your people are burned out compared to kind of the national average, right? Because I give them data about how we are nationally across all of these different fields. So kind of interesting to ponder before we get there. So the data analysis is your standard thematic analysis. It was driven by grounded theory, and grounded theory is kind of constant data collection and comparisons. You're kind of simultaneously collecting and analyzing the data. You're doing memoing. I used a semi-structured interview guide with no COVID adjustment. So once COVID started, people were still getting the same questions across all the interviews. And while I didn't ask about COVID, they did kind of organically start talking about it. I used Atlas TI and also Word. And, again, this is your most standard qualitative methodology possible. We started with the line-by-line coding and then went to thematic sorting, which if you were doing real grounded theory, like formal grounded theory, would be your focus codes. And then we did theoretical sampling, the re-interviewing of certain people. And what emerged was one overarching theme with 3 categories. So the primary theme, we're finally down, we've kind of done all the housekeeping, and we're finally down to what we're here for. Mission-driven ethos to mitigate provider burnout. What is that? This was how safety net administrators in our sample described using the organization's mission statement as their driver of clinical culture and training to mitigate burnout. Now, I think we talked about it a little bit in the bio, or maybe we didn't, but I'm like a first gen high school grad, East LA, Latina in research. And there's a lot of experiences that I and like my fellow kind of similar cohort have had. And it's always a little frustrating to see people publish manuscripts that are what we call duh research. Like, yeah, we know that. That's it's known. But if it's not in the literature, we can't cite it. So when I came to this kind of overarching theme, it felt very duh to me. Like, yeah, of course, people who are working in these underserved communities are using this ethos-driven motivation to get people to work there, right? Because why else would you work there? I can't imagine anybody works there for any reason other than mission-driven ethos. And so this study was helpful for me because actually I'm wrong. And that's what I find when the deeper I stay in this burnout research, is that a lot of it is counterintuitive. And that's unfortunate because we're making a lot of decisions right now, especially during the pandemic, that are based on what feels like it should work. And then we're kind of perplexed. Why didn't they like the meal delivery service? That was very expensive. We thought they would like it, right? So there is some stuff that is going to shake out. And it goes into these two categories. One is promoting the mission, and this is somewhat the positive aspects of this theme, and competing priorities, which not the negative aspects, but the stuff that is not duh to me, stuff that I really didn't know, and things that I kind of didn't assume because of what I know about this population. So the first category, promoting the mission, is about how administrators convey and perpetuate the organization's mission to compensate for demanding and at times unrealistic expectations, right? So they're using it because they know that you can't just ask people to do their job in this setting because there is no way that you can actually compensate them for what they're doing. And so they start off what ends up being sort of like a workforce timeline. They start off by actually actively recruiting bleeders. And that's the first property of this category. And bleeders isn't my term. I had a few different people have terms that they used, actually more than one used bleeders. Sometimes they were like well-meaning do-gooders or the overachievers. Like they had nicknames for these physicians especially. And so here's a quote. "We look for the bleeders, bleeding hearts, or deeply committed individuals." And what they also said, actually the person who gave me this quote said, "We're not looking for qualified, we're looking for mission fit." And this person, who was a major force in the hiring of their organization, said they will turn away Ivy League educated, well-trained physicians if they're not mission fit. And so this person, this isn't written up into the formal paperwork of who we're hiring. So people across these organizations were making these decisions. They developed these heuristics of who the right person is. And it was causing them to leave a lot of the candidates kind of on the table and not really consider them. And this resulted in chronic understaffing. We're always hearing that there's understaffing, but this made it worse because they had viable candidates that were being ignored. And there was a disconnection between the needs of the organization and the recruitment strategies that were being used. And so it's something to think about. Once the people were actually hired, they went about promoting this mission-driven identity at every turn. They were telling people it's a calling. You're not only doing your job, you're becoming an ambassador. And in with this kind of framing was that this challenge is noble and self-sacrifice is part of it, but it's never ending for people, right? It's not like, yeah, we're going to go, fight the bad guys and let's go march and let's do it. And now we won or we lost, but we're all coming home holding our spears. That's not what this is. This is go fight in endless crusades and never come home. So if you're there and you're really pushing this mission, it has to basically end in you being done, right? You leaving the organization or you giving in completely, because this will never stop. And that was the impression that was kind of counter this philosophy, because you had a mix of employees, the people who had just started, these bleeders, who were with people who'd been there for a very long time on this kind of never-ending trek. What did seem to help, though, is a lot of different organizations had started trying to reinforce this identity and allow people to process the trauma that they see every day in their clinic. That's a lot of social determinants of health kind of negatively impacting the experience, by allowing them to make some connections through upstream efforts to actually address these social determinants of health. They did that through volunteering, through actively engaging in research programs with the local university, by just peer bonding, right? So they would do these kind of like case debriefs, like you would do, you know, I don't even remember we were in training what we would call them, but you know, getting together and just kind of processing what happened that day. It seems like more work, but volunteering reminds you why you're here. This is a group that went and did a lot of things over the weekend to deal with some of the food insecurity that's been happening. I use my practice in my research and the research in my practice. It makes sense and it's exciting. This is one of the leading endocrinologists in the field today who is very explicitly saying, this should be how we drive research from clinical information about what's happening now. And so people who were doing these outside activities, obviously it took more time and energy, but they actually seemed to be happier about where they were, and the clinics that did this had better retention of staff. Oops, sorry. So that was kind of the somewhat positive, and now we're going to get to the competing priorities issue. And again, we're about halfway through, but feel free to interrupt me if you have questions about any of this or you want me to clarify something. So the second category is competing priorities, and this was about the personal and logistical challenges administrators face when they're trying to meet the competing needs of the provider employees, right, who they identify with. Most of them used to be one of those people, and the organization, which at the end of the day is a business, right? So those competing financial and human priorities were a big part of their daily lives. And so one of the biggest complaints was how they processed the patient caseload that they essentially needed to assign every day. You can't provide good care when you're seeing that many patients a day, but we have to keep the lights on, right? Overscheduling is common in this place. It's sometimes double and triple booked is the standard. And it's a product of low compensation, generally Medi-Cal, or it's probably Medicaid where you all are, which, you know, can be as low as like 15 to 30 bucks per patient per visit. And appointment attendance, which is going to be lower in these communities where people have competing priorities themselves about this appointment. There may be financial restrictions as to why their transportation didn't pan out that day, or other childcare concerns, or their job may not allow them time, right? So there is this expectation that a certain percentage of the patients will never show up, so you have to overbook. Would anybody like to guess the range of patients seen per day at these clinics per provider? So how many people is reasonable to see a day? If anybody wants to try, feel free to guess. We're looking for a range here.
You looking for reasonable, or are you looking for what they're really seeing?
What do you think they're really seeing per provider?
I think they're seeing upwards of 20 people a day.
I agree. That was my assumption.
Which I don't think is reasonable.
No, I don't think it's reasonable either, but as shocking as it is, the range was 8 to 60. I had one clinic that regularly saw between 45 and 60 patients per day per provider, because they're a rural clinic. There was very little, there's very little assistance in the area. People were grateful to have it, but yeah, this is the reality. Providers are sometimes spending 5 minutes with the patients because this overbooking is putting them in a situation where they're missing all of their breaks, and immediately they show up and they're 5 people behind who are sitting in the waiting room. So this is kind of where we are. And this actually seemed to have gotten worse once we switched to telehealth. So we could talk about that after we're done here. But yeah, so that's a problem, right? Because there's no way it's not impacting care somehow. But then there was this larger issue, which actually is kind of the title of the paper that I'm about to submit, which is leveraging bleeders and billers. The reality is that we all assume that the people in the, at least I assume, the people in these places are bleeders. They're there because they care about the mission. But there's actually a whole other group of providers who are competent and qualified and well-meaning, but aren't there for that larger ethos mission. That's not their motivation, right? So exploring kind of who these billers are, a lot of the administrators said, billers, you know, I mean, they're great. They were like, oh, they're wonderful. They'll see all these patients. They'll take on extra patients. They'll stay late, but they'll leave as soon as they're done. They are not looking to put down roots. And when they mean as soon as they're done, there was this thing called the 2-year, 20-year problem, which I actually heard that exact phrase said across a couple of different environments. So it must be some insider talk. But the 2-year problem is the people that are there at these clinics for 2 years. Well, why would you only be at a place for 2 years? Student loan repayment, right? So there's a lot of people who are there because medical school is way too expensive. Most of this clinical training is. So people are going to these underserved environments to kind of work off that time, but they're never intending to stay. And there are consequences for that, and the least of which is just lots of turnover. But the 20-year problem was also a part of this, which was that long-term bleeders can become detached and jaded. And detached not just from the patients, but from the evidence-based practice that we do. You know, science moves fairly quickly. It moves a little slow when we're talking about translating from the bench to the actual, you know, exam table, but in general, you can go into some of these environments and see people doing things that we haven't done for 10, 15 years. And so there's also some early evidence that people who are extremely burned out are unable to leave, that the people that leave are the ones who still have the internal reserves to get out, right? So you've got this now environment where you have some people who are not there for the ethos. They're really just trying to get their job done. They're not trying to make emotional connections with patients or their peers. And then you have other people who probably aren't open to making connections because they're jaded and just kind of frustrated being there, and they've just kind of emotionally shut down, right? So this is a problem. And then compounding this is the last theme, the last property, which is staff shortages help bad actors. And this was about the fact that, and I'm sure we've heard this impression, some people work here because they can't work anywhere else. And there was all sorts of reasons why people thought that the type of care that you received and the quality of employees was lower at an FQHC. It didn't have the same shininess and prestige of working at like an R1 academic center, right? Or a bad apple spoils the bunch, which, you know, is a malapropism, but basically having somebody there with bad attitude can taint the entire environment, except don't forget, we need to keep the lights on. So what was happening was that disciplinary decisions were influenced by staffing needs, which meant discipline was being slow rolled, and people who would normally be immediately fired for insubordination or the treatment of a patient that was inappropriate or just missing, you know, missing rounds or whatever it was that would normally get you, you know, kicked out that day would be kind of downplayed. You know, I heard a lot of really bad stories of staff openly arguing with each other in the nursing station, or like different things happening that you just can't believe the person's still working there. But what happens is not only does that person get to stay, but everyone gets to see that the overall level of civility in the clinic just kind of drops down a little bit because the standards suddenly change. This was the last thing that came out about bleeders and billers, doing some of this theoretical sampling. These people, instead of bleeders and billers, were also called renters and owners. And that's interesting to me. I have a house in Los Angeles, and you know that comes with all sorts of issues. But trying to rent here, it's extremely expensive. And part of that is that you expect to be able to ask for anything to get fixed right away because, man, I'm paying so much to rent here, and it's somebody else's problem, and I don't have to do a thing. But when when you own a house, any little thing that breaks down, you have to pay for. And then you start kind of trying to be creative and strategic about how you're going to, you know, balance the budget to pay for this thing, but don't forget this thing is going on. And it really involves this kind of active engagement in maintaining your environment. And that really rang true for me in terms of what I saw with the bleeders and billers of how much do you own the reality of your situation, because that's going to in some way influence how much energy you put into making it nice and how much you're just like counting down the time before you get to switch out for like a nice high-rise spot that doesn't have these same plumbing issues or whatever. So if we were to take these two types of providers, you could theoretically build the framework like the one I have here. Very preliminary framework because this is the first time I'm coming across these data, and I'm going to have to do some real exploratory stuff over the next few years to really tease them out. But in theory, if the house is on fire and we want to do something right now, we should recognize that there are different types of people in these environments, not just kind of the bleeding hearts that I thought were probably working there. But if you recognize and stratify your employees accordingly, then you can make sure that you're covering all of the different motivations that probably need to be touched on to keep this a positive place. So for the bleeders, these people are mission driven, and they actually want to see fewer patients per day because they believe that more patients compromises the quality of care delivery. So if you were going to try to mitigate their burnout, you really want to improve access to these upstream activities, right, that support their personal growth in the role and also reaffirm the meaning in the work. You want them to be able to see some positive outcomes from all of the energy that they're putting in, right? And then you have billers who none of that's going to work for them, right? It's kind of falling on at least uninterested ears. These people are compensation driven, even if that compensation is just paying off student loans. They want to see more patient visits per day. They want because they believe that more patients adds value to the clinic, and in some places they're expecting that compensation to reflect more patients, right? And they're motivated by kind of what would cause you to be a scientist clinician, right? You actually enjoy the aspects of giving care that aren't about emotionally connecting with someone, right? So that is the problem solving that we have to do, coming up with the differential diagnoses, trying to figure out what's going on, trying to strategize, working within this health system to be able to secure, a bed somewhere, for example, when you know that places are full. So the burnout mitigation strategy for these folks is to improve infrastructure to support them working to the top of their scope. Kind of don't have them do things like patient education that's going to slow them down, and they're not really going to be in a position to say it with empathy and understanding and be willing to get feedback. You really want to put them in spots where they're using their kind of scientist analytic mind as much as they can. And that can be really helpful in this environment. The other thing is that you really want to consider student loan assistance. If the reason they're bailing at 2 years is because they were only there for the financial aspect, you might be able to recruit some people who aren't there specifically for that reason. And, student loan is a hot topic right now anyway. But I'm going to ask you all now, and again, feel free to respond if you want. You don't have to if you aren't feeling comfortable. So there was this recent Medscape 2020 provider compensation report where they asked providers, it's like 17,000 providers nationally. So it's like a decent representative sample across 30 specialties. And they asked them, what's your primary motivation, like the thing that you find the most fulfilling about your job? And so I categorized these different responses that they could have as being associated with bleeders or billers, right? So like emotional connection and that sort of thing, as opposed to the rewards of kind of like the scientific analytic challenges that are fun. What percent of this group do you think is bleeders? So how many clinicians do you think, what percent falls into this bleeder category?
I'd like to think it's most.
I would like to think that too. So you're thinking 80, 90%?
I don't have a finer point on it than...
That's okay. I mean,
I don't know that I was thinking quite that high actually, but I was thinking it was definitely north of 50%.
Okay, so you weren't thinking like 27%.
I was not.
Yeah, I wasn't either. And this, I think, is part of the issue that we're going to talk about in a second. So then and don't forget, they gave them a variety of different answers. So 27% is one of the biggest groups of providers. What about the bleeders? What about the billers? How many clinicians are strictly billers? I know nobody really wants to say.
I think it would be higher because I think a lot of people, I have colleagues who go to rural areas to pay off their loans. So I feel like this would be, I don't know what the exact number is, but I would say billers exceed bleeders.
That's an interesting thing. I hadn't assumed that, and I haven't heard it, but you're pretty spot on. It's about 23%. Yeah. And don't forget that these two answers were actually, they were spread across a variety of answers. So these represent large shares of people's responses because there were other things that were like, it's a family tradition or things like that. The reality is that if this was a representative group, and there were the three primary care specialties that we're mostly talking to in these studies, well represented. It's possible that in these FQHC environments, you're working with a group that's like 50-50. And yet, if you look at these burnout mitigation strategies, the one on the left, for me at least, for the bleeders, is what I'm seeing in FQHCs and in other safety net, like the FQHC lookalikes. That's what they're using, is these kind of like, you know, bleeders support mission-driven ethos. But if you work in the hospitals, and I did a big analysis at the Stanford Med Center, they're using the one for billers, right, which is infrastructure support, streamlining EHR, you know, using physician extenders, doing all of that kind of stuff, right? But what if we have a combination of providers at both places and we're just not really doing enough to make sure that we're providing what people need? Because I think, you know, I live in California, as I mentioned, and I live in an area that is extremely liberal. And it can be sometimes shocking to get news from the rest of the country because it is such an echo chamber here that I just believe that everybody is, you know, kind of sharing these same views. And I work in healthcare and I study under-resourced communities, right? So like it, without me even noticing, I've surrounded myself with people who are very much like me. And it's really prevented me from being able to see that there are other perspectives going on unless I actively seek them out. And I think that might be happening with some of my administrators. They're really seeing the people that they wanted to hire instead of the people that are actually there. So I told you this kind of crossed over COVID. These were some just additional themes that I haven't broken down into categories, but just so that people kind of know what's going on the ground right now. There's a lot of spontaneous coverage behaviors that are happening. If I had a no-show, I'd go see the patient for this doctor and make sure they're okay, and they kind of went on. And then I'd go see this one if they weren't, and then we do this. And normally that doesn't happen. We created a mutual support space for peers. And they're talking about how in their environment, nobody would ever check up on anybody to see how their day is going, and now they are. So there's this renewed flexibility and reciprocity that's happening, and it's really bolstered a sense of teamwork that seems to be helping. One of the big motivating factors for a lot of these spaces was frontline staff seeing the administrators who they only ever see like in suits and ties and stuff, actually on the front line, show up in scrubs and go out there and give vaccines. So if you're an administrator, you're in that position to kind of recommend it to somebody. It's important that we kind of get that sense that nobody is being spared from the reality of everything that's going on. We're all kind of in it. And now don't forget, a lot of these interviews were near the beginning of the pandemic, and they're not, you know, I'm not doing new interviews today that are necessarily showing this, but at least initially, provider staff was really galvanized by the pandemic, right? People really felt like this was, you know, all of a sudden somebody blew a bugle and we're here, right? This is what we trained for. It's looking like the country is in an emergency and it's basically all hands on deck, right? So it reinforced this larger mission-driven identity that people had. And it was beyond just working for their organization. It was this sense of who I am. I'm a nurse, or, you know, I'm a pediatrician, right? Like, and we are this brother and sisterhood that has meaning. But part of that was that a lot of people got sick, especially early on. I had COVID for about a month and a half, really bad. Well, a moderate case, which is actually pretty bad with COVID, and it was near the beginning of the pandemic. And I felt incredible, you know, sadness and stress that I wasn't helping. So I started this project where I was encouraging providers to submit haiku about their experience of just dealing with COVID. I called it high quarantine hashtag. And a lot of the haikus that came in were surprisingly reflecting what I was feeling, which was we're too sick to be out there. And we're feeling this real survivor's guilt. Like, even though we're sick, we're not actually able to do as much as we feel like we should be able to do because it's all hands on deck. And so there's all sorts of intricate mental health aspects of what we're going through that we haven't even begun to look at. And it's going to be an interesting time and place for mental health and emotional wellness research over the next probably 10 years as we try to tease out what's going on. But this environment does create a unique opportunity for billers because we need people, we need bodies, and we need people to see a lot of people per day. And we need people to not be completely dispirited if possible, because we're seeing some pretty rough stuff, right? I've seen more mortality in the last year that I've seen my entire practice. So I think that billers at this time really could shine if we recognize the benefits of having them around and then we leverage them appropriately. So now, this is a little different than what we asked before. Do you feel burned out from work today? So just kind of take a second and think about your morning and, like, you know, just take the temperature on how things are. So I'm not asking you all to do a poll, but traditionally when I do these sorts of presentations, the how you felt over the last month feels pretty bad. It's up in the 80s. And then how do you feel today? Are you burned out today? Tends to be quite low, tends to be in the 20s and 30s, which again is not zero. But then I talk to people a little bit about, are you a bleeder or a biller? In your heart, which one are you? And it's okay to be either, obviously, because we need everyone. But even if I don't ask people to call out, if the chat box fills up with like bleeder, 100% bleeder, right? Because there's something about the type of people who come to these sorts of talks. And so feeling like you were engaged in research and you were learning about something, if you're that type of person, this may have kind of taken your internal temperature down a little bit because you're kind of reminded of a larger thing and you feel engaged. It may be the reason that some of these other activities, these upstream activities are helpful, but we have a lot more work to do to figure that out. So the lessons in the data are, you know, COVID's terrible. I don't need to tell anybody that, but it is going to get resolved, right? But there will be new threats. There will always be new threats, and we're going to have to rise to meet that challenge. So we can't be scared to talk about burnout because it's there. It's not something that we create. So I told you at the beginning of the show that there's a lot of people who are like, I really want to help you. I want to meet with you, but I just don't have the time. But there was another group that was like, don't come in here talking that burnout mess. Seriously, do not come over here and tell people that you're doing a burnout study. Because the second my staff hear the word burnout, I'm going to get call outs because you're giving them the language to use against me. Don't do well-being activities. Just don't even mention it, because we're already struggling. So there was this sense that once people were able to identify and name what they were feeling, and there's tons of evidence of this in terms of like racism and other sociological concepts that are really damaging. There's tons of evidence about this in the literature, right? Once you give people the language, then they can identify their reality. However, what we know in terms of teenage suicidality, for example, is that there used to be this, let's not mention it because then we're putting the idea in people's heads. Same thing with like contraception. Don't talk about sex because then kids will start thinking about sex, right? But what we've learned is that talking about it doesn't make us any more likely, or doesn't make them any more likely to act on things, right? Their reality is their reality. But if you give people the tools and the evidence that they need, then they can make intelligent decisions about how they feel and what they'll do. And by and large, it doesn't increase suicide. It doesn't increase sexual behaviors, right? So maybe it doesn't increase burnout. It's a little bit of extrapolation there, but conceptually, it kind of makes sense. Really, we just need to see burnout as normal, part of the job that's expected, and leverage evidence-based solutions, not just logical approaches, because logically, mindfulness works. However, they just put out this study of pediatric residents who were required to do a mindfulness intervention, and it actually increased all of their burnout. No idea why, other than potentially because it's just one more thing they're required to do, right? So we can't just kind of guess what's going to be good and try to implement it, because people take things well or they don't. So the most important thing that I think comes out of this work is, who is this provider? You need to know who they are so that you can staff and reward accordingly, so that they're actually enjoying what they're doing, because that helps them have some empathy and connectedness with the actual care delivery that they're providing. Teams and strengths-based approaches are really kind of being pushed by the Academy of Medicine, and they seem to be effective, right? So for volunteering, that's really good for bleeders, kind of reconnects them with the social justice mission. for the billers, engaging them in research, giving them opportunities to come to talks. Even talks like this will make them feel like they're part of something larger and feel like it's fun and exciting. And just really sponsoring these peer and group activities that allow people to decompress with people who understand, whether they've totally bought into this ethos or whether they've just like had to do some pretty ridiculous stuff today. Being able to talk to somebody who's not saying like, oh, the printer jammed all day today in my office. You know, that can be really challenging to be around people who don't really get your reality. So I'd like to thank all of my mentors at UCLA and Charles Drew University and at Stanford. My collaborator, Dr. Kim at Cedars, she's great. She's looking at the effects of burnout on telomeric link, which is really interesting. And then my site partners at Ultimed were really helpful. So this is my contact information. I'm only going to be at UCLA until June, and then I'm moving on to my next position. So that LA Muralist is my personal address. Feel free to use it. I started off in research doing mural-based interventions like 20 years ago, so that's why I have that email. And then I think we have time for questions. So I'm going to stop sharing. But thank you all for listening.
Thank you. Thank you so much. We do have some time for questions. And so as you're thinking of them, please speak up. We appreciate your conversation. You're just, you know, this isn't an area that I've been heavily involved in, although I have approached a little bit burnout through more of a quantitative lens. So it's been helpful to unpack some of that in a more of a qualitative way. So I personally appreciate that. Thank you. I see some people turning on their cameras. Is it because there are questions? I'd invite you to speak up. Just jump right in.
So I just have a question about the very first thing you asked, which was how much I felt like I had work burnout. And I've had this question about burnout before, which is I feel like I can't differentiate where it's coming from. I mean, I feel frequently burnt out, but I have work and 3 kids, and so I didn't know how to answer that. Can people generally figure out where their burnout's coming from? Does it matter?
I mean, it's generally seen as so believe it or not, burnout is supposed to be restricted to like clinicians, for example. I'm trying to advocate to admit that patients and just other people in the world have burnout, because that term isn't usually allowed to be, you know, used for other things. And it encompasses these realms like depersonalization and, you know, the issue is that, yeah, it's holistic. So it's ridiculous to think that you should be able to tease that apart. I have to say, as a middle-aged woman with children and a husband who works full-time and all of that other kind of stuff, it's definitely my reality that there would be no way I could separate it out. And I think that it's just, you know, our complicated modern life. But I do have friends that work in industries that they don't take it home with them. And they don't have mental images on the front of their brain. You know, I worked locked psych with mentally ill offenders for a lot of years. And those images are never going away, some of them. And so you know, a big part of burnout that we haven't talked about very much is this secondary trauma. That's kind of the newest direction of the research. Dr. Shervington, who's down at Tulane, is really the specialist on that. And so that's all I would say is, yeah, modern life isn't it crazy? But also we've picked a field where we're exposing ourselves to some of the harshest realities of humankind as a matter of, you know, our daily experience. And I encourage everyone, best advice I got in my PhD, you should always be seeing a therapist. When you're treating other people, you should always be seeing a therapist, because even if you just go and talk to them about like traffic, you can't expect the people in your social environment to process the things that you are uniquely dedicated to. So I don't know how helpful that was, but man, I feel ya.
So thank you for your presentation. My background is in critical care, where there's been a fair amount of burnout work done, and I so appreciate this shift away from the extracurricular things you need to do to make yourself better.
Yeah.
Is such a blaming the victim maneuver. So I really feel like it has to be integrated. And I'd also like to just ask, you talked about clinicians and you talked about billers and bleeders. And I just wonder how interprofessional the organizations you studied were, or was the focus strictly on people who were revenue generating, so to speak?
Yes. So I worked specifically to address MDs, NPs, and PAs because some of my other work, you know, I know Dr. Nancy Blake really well, and I know Jack Needleman, and they do all of the staffing stuff that has to do with RN burnout. And, you know, even at Cedars, when I work with Dr. Kim, like our latest manuscript is on like what specific activities that are assigned to registered nurses at the bedside cause the most burnout. And these are completely different fields. They might as well be studying like physics versus chemistry. They really are not the same. And so, unfortunately,
can you explain why they're not?
Oh yeah. I mean, in the first place, we're educated differently, right? Nurses are brought up from birth as a nurse. I know because I started off as a CNA and I've done the whole career ladder, right? Everything is teamwork. Everything is building relationships and coordinating and actively managing the emotional burden of maintaining all of these relationships to get stuff done. If you've never done that level of care, you don't know how many personal relationships you have to maintain just to turn a patient, right? Like if you didn't behave early, and nurses have a long memory and it's a small world, right? So you have to be, you know, this emotive person par excellence to work in that field, but you are also systematically kind of kicked because the hierarchy puts us lower than physicians and other billers because of the way they're treated, because they're billers, right? And I know this is somewhat controversial, but I'm just going to say it. So there is different research being done for the people who have these billable units than the people who are salaried individuals. And it's unfortunate because the salaried individuals are spending the majority of the time with the patient, but also with each other. They don't get to pick up and leave the unit after a half an hour, right? And so, so yeah, I've strayed because you got me emotionally fired up. But yeah, no, it is. It's different and interesting. And the fact is, the reason I wanted to do work in the safety net setting is that most burnout research is done in critical care, ICU, NICU, emergency department. Like these are very highly like well-funded, even if the people aren't paid what they, you know, necessarily deserve. They're very well-funded and they charge a bunch, and the hospitals care a lot about them, right? But that doesn't necessarily mean that translates anywhere. And having done a few rotations in these different settings, the nurses in the ICU who are capable of that work, the nurses in the cardiac cath labs are different than the nurses in peds. They're different than the mental health nurses. You know what I mean? So yeah, I just want us to know more. I'm sorry, please go ahead.
No, there's emerging research that, you know, if there is this, if we don't process these experiences together, if, you know, physicians are, I'm talking like, if you've read about Rana Adish, a lot of her work, you know, if you don't process this together, because we experience this together, we're not going to integrate these experiences in a way that's going to prevent and allow us to continue to provide compassionate care.
No, I totally agree with that. And I agree with it on an organic level in terms of how our brain stores memories. I think that's very true. But in my space where I'm working with a lot of first generation providers of color who are from these neighborhoods. And what I'm seeing with them too is that so I had one lady that I interviewed a couple of times, and her mother was a victim of a gunshot wound. When she was 5, she was walking with her here in South LA. Mother was shot, got Carroll County, and it encouraged her to become a doctor because what she saw was not great. But she regularly sees gunshot wounds. And so she, unfortunately, when they come in, she was telling me she gets this like immediate panic and anxiety and, you know, will sometimes go in the bathroom and cry. Not because she can't handle it, because she's a provider and she does her job, but the connection that you have personally to trauma when you grew up in these places is interesting. And we're not really doing anything to recognize like how much does this connect to the who you are. And so, man, there's so much to do here. But I would love to talk to you more, any of you, if you guys want to talk.
I have to go to another meeting, but thank you very much. And I do appreciate your work.
Thank you.
Great, thank you so much. I know we're coming up to the end of our time here, and I don't know whether there are other questions or whether, Adrienne, you're able to or would like to hang
Yeah,
on.
I was going to say, I'll stay on for 5 minutes if people are interested in talking, but obviously if you have something, go do your thing. Our never ending Zoom meetings. But thanks for letting me talk to you all today.
Thank you.
Hi, Adrienne. I'm also very curious about, I like this idea of thinking about an individualistic perspective on what makes someone, you know, more burnt out than another person, especially thinking about where the individual comes from. ICU nurse being inherently different than a nurse working in, say, med-surg floor. One thing I'm curious too about the individualistic traits of bleeders versus billers. Like, what makes them different? What makes someone more likely to be a bleeder?
Mm-hmm.
I mean, have you ever looked into that? I'm just curious your thoughts.
So this is all super new. No,
Yeah.
but I haven't looked in it. It should be looked at. But I think that I have some selection bias in my sample because I have a lot of minorities, of first-gen minorities who basically are coming from these environments, and they were motivated to do it in the first place because they saw some bad stuff when they were growing up. And so I think I have a lot of bleeders that, you know, maybe makes this not very generalizable.
Yeah.
But yeah, I think, you know, historical instances of trauma and personal experiences probably matter, but there's a lot of psychology research on like how your personality, like, you know, your optimism versus pessimism and all these other things can kind of affect you. What's interesting in nursing, good and bad, is that we're known for eating our young. That when you graduate, you go out on the floor. If you get a job on a unit, you usually have to kind of, people know you or you know somebody. But if you get there and you don't prove yourself to the veteran nurses that are there, you won't be there long, because you have to kind of earn your space and earn our trust. And once you do, the support and coverage that you get is usually phenomenal. Right. And I don't know that the you know, billable providers do that. I don't know that they kind of group each other in and create a cohort and say like, this person has screwed up too many times and you can't be here. And so we're going to like report you until we get you out of here. Like, I don't know if that happens, but I know that it does with nurses. And that's why I've loved working with National Clinician Scholars Program, because my experience with physicians to date has been working with them showing up when I'm doing clinical work. Mm-hmm. And I've never gotten to know them intimately or know anything about their training. And it's a huge disconnect in healthcare. Why don't we know anything about each other and how we were trained? So I could go on about that forever. You should see the classes. You know, going to school with mostly women and, you know, nurses for the last 12 years, we all talk and everybody's like offering suggestions and whatever. And then the classes that I have with physicians, they don't raise their hand unless they think they're right. It's silent. There's a lot of pressure to look the right way. And man, that must be limiting. I don't know. It's a big generalization, but we're officially done, right? So we're just answering questions in the back room.
I do see there's a question in the chat, which I believe it was from Monica DiNardo. I believe she had to leave, but maybe we can, I think we're still recording. Maybe I can ask it
let me
for her.
read it. Yeah, I'll just read it real quick.
Go for it.
Oh, mindfulness researcher.
And
yes.
maybe just because I don't think the chat gets recorded.
Oh, I'm sorry.
Summarize what you're going to answer there.
So she brings up some really good points, which it sounds like she has a background as a mindfulness researcher. And I do want to make sure that it doesn't seem like I'm saying anything bad about mindfulness. There's a lot of fantastic evidence that mindfulness is effective. It's just probably not effective if it's forced on you, which is kind of what I've heard in a lot of these settings. And that there are problems. It's problematic when you systematize and dichotomize groups so that they're getting different care. I agree. Again, this is very superficial data, and thematic analysis is designed to create sets. That's kind of how ranking and, you know, sets works in this type of methodology. But all it does is give you opportunities to do deeper explorations. So what I will probably do is check and see if there is some sort of established quantitative measurement tool that I can use to see if I can tease apart different aspects of people's personalities when I'm doing some larger intervention. That's how it kind of plays in. Research isn't, unfortunately, leaps and bounds. Research is strategic, careful, thoughtful, step after step after step. And so if you're doing it wrong, it's sexy and it gets into the news. But if you're doing it right, it doesn't look like much for like 10 years. So unfortunately, that's the way it is. So I agree with everything that she said. And there is a risk of elevating these billers. But I think that's already happening because they're valued, because they're making more money. But as a utilization review person from a long way back, giving care the right way is actually the most cost-effective approach. And we know, especially in these outpatient low-income settings, connections with providers and empathy is strongly correlated with whether or not people engage in preventive care or even like tell you honestly whether they're adhering to their medication regimen, right? So we know that it's not cost-effective as it is now. So this does take some really broad thinking. It would really benefit from Medicare for All, honestly, because it would allow us to make decisions not based on billing in the same way. And then her last question was, if 27% are bleeders and 23% are billers, what's the other 50%? Unfortunately, when you're using like a pie chart, the rest of the 50% can be broken up into relatively small, somewhat meaningless units, and that's what happened here. So like I was saying, there'll be like 10% are doing it because it was a family business and 5% are doing it because of, so there were a bunch of other things that were relatively non-significant, but it is the Medscape 2020 provider compensation report, and it's free. You can get it online, and there's a lot of really good data in there. I kind of, I pieced it together in a palatable way because it's a lot of kind of raw data, but you can definitely find that in there, or contact me if you'd like, because I'm always happy to talk about this. And I have never met somebody who hears I do burnout research who isn't like, oh, let me tell you, because everybody has a story, and they're all relevant and valid. And I don't know why we shut people down, because if somebody told me, if I just said I'm studying diabetes like I used to, and people were like, let me tell you about my experience, I would be like, great, tell me, right? But we act like burnout is a dirty little secret that we're not really supposed to talk about. I'm riffing here, but because, the establishment of our career is built on Puritan, ethics, which is really about a strong sense of work and commitment to what you're doing, and being burned out seems like you're weak or you've failed. When in reality, it's just what's happening because of the mismatch between demands and the availability of these services. So anyway, but yeah, thanks.
I have one more question. I don't know whether, Tiffany, do you want to jump in with your question?
I have a question, but maybe I'll pose my question after you, because it's kind of about the subject matter, and it's kind of a little bit else. So maybe you want to ask your question first, Andrew?
Sure, I'm happy to. So when you're talking about billable individuals who can bill in the healthcare setting, you're calling to mind for me a researcher who I know at least one of the goals he has in his research trajectory is to do the research that would enable nurses to bill, like to make nursing care billable. And I wonder what do you see as the impact of that, if any, in the context of what you've presented today? Is it helpful? Is it just make things more complex? Is it something? What are your?
I mean, I think it would change how people see us, because I have to say, I have a PhD. I have like this prestigious postdoc. Like, I could have given you a very long bio of kind of my background, but I have yet to attend a meeting where I'm not asked to take notes or bring coffee. And so I think there's something that we just haven't gotten over in terms of valuing what nurses contribute, and money seems to be the thing that convinces people, right? So it seems like it would be helpful. The problem is that you could bill based on outcomes, but otherwise nurses do so many things for so many different people when they cover their shift, it would be really hard to track unless they wore sensors or something. I don't even know how you would bill for them. And also, I've had patients where, you can tell I'm a talker. I'm a psych nurse, you can tell, I'm totally sure. But I've sat with patients who really just needed me to do some physical intervention, and I've done it, and I know they're not talkers, and I'm respectful of their space. But I've also spent huge chunks of my time, doing manicures and pedicures on people who've been homeless for 5 years, and, cleaning nits out of hair, which takes hours sometimes, and time when you're actually like talking and singing with them and getting them open to a place where they can talk about the trauma, sometimes the assault that brought them in the first place, right? Like, this is stuff that can't pay somebody to do that stuff. There's no way to compensate for it. But you also can't punish somebody who doesn't want to sit there and sing with their patients so that they get them talking. Unfortunately, medical services are procedures that have step by step by step, and that makes sense to bill for them. What nurses provide, what we're trained to do, is holistic care. We're the only field in medicine or in clinical work that does that. So we care about the mental, emotional, spiritual, physical, sexual health, death and dying. All of that's our purview. And the benefit of that is that because we're not disease process focused like medicine, death isn't failure to us. Readmission isn't failure to us. There is no failure to us except for if the patient is unhappy with their ability to be who they want to be in the moment. And how are you going to bill for that, It's so tough. I just wish there was a way for us to know more what each other do. Because I can't imagine if I sat with a physician who is, working on these incredible cases and terrified because they're doing surgeries on infants that are like this big. Like, I can't imagine that I wouldn't grow in respect if I knew that. And I also can't imagine that you wouldn't be pretty impressed if you heard how I was dealing with suicidal teens, And so, I don't know, man. There's got to be a better way than we're doing it. But I wish the money didn't matter at the end of the day. Anyway, look, I'm getting all like, I'm sorry. Okay, Miss Tiffany, you had
that was actually a great answer. A great answer. It doesn't solve the problem, but it was a great answer. So my question was a little broader. First, I just wanted to say thanks for this wonderful talk. I enjoyed it immensely. And I guess one of the things that I'm really impressed with about your work is the way that you have kind of a patient-centered research focus and clinical background, and then also kind of a platform for using your research to inform public policy and advocacy on like a larger level. And one of the things that I'm just really interested in, and I would imagine a lot of people here at this Health Policy Hub are, is, how do you do that? I mean, I think that every scientist should be able to kind of use their work to inform public policy and to inform the marketplace. But do you have any kind of suggestions or recommendations for people like myself who's 1 month into a postdoc right now? Or I know we have other PhD students on the meeting right now, of just kind of avenues to really, aside from something like this that draws people in. I would just appreciate any kind of insights, recommendations, or opinions that you have about that.
Oh, I appreciate the question. Please get a hold of me. I would love to talk to you, and anybody who wants to talk more about, a policy slant to all of this. We actually did a part of our postdoc was going to the Capitol and hanging out with legislators and kind of understanding what was going to be palatable to them, because frankly, none of us would be doing what we're doing right now if we weren't kind of this 1% of people that are like super achievers, balancing all of these things, trying to get the data, used to being in competition. Like, it puts us in this situation where for sometimes decades, we've been in competition with each other and ourselves. And that tends to have us feel like we need to justify why we're there and kind of prove to people that I deserve to be here. And that can result in us talking higher level than a lot of legislators want to hear or can hear. Right? Because a lot of elected officials don't come from this sort of background. As we've recently learned, you can be a fairly well-known legislator. So Anyway, so yeah, going to the Capitol and talking to some people, you know, Dr. Richard Pan, who's a dentist actually, he's a physician who does vaccine work here in California. Talking to him, he was the only one that we were able to talk to as though we were talking to colleagues. Literally everybody else we talked to was not ready for the high level discussions that we're all so used to having with each other. And so it's important to just keep in mind that it's nice to be able to be like, it's true, but you know, 27% of providers don't identify that way. You got to be able to say that. But what's more important to them is a story about like, well, the thing about Christopher was when his mom tried to get care, she was turned away. And that sticks with them in a different way. So I think it becomes like the one thing of like letting go about your identity. You deserve to be here. You're obviously one of our best and brightest. Otherwise you wouldn't be in this program. And so cool, we're done with that. You don't have to worry about it anymore. And now really focus on like emotionally connecting with the people that you want to influence. And again, that's often through stories. But yeah, the best lesson for me, honestly, was that my husband's a Caltech guy, and he's brilliant. And you would never know it because he never, ever talks above anybody's head. And it really is a true sign of you mastering your topic if you can explain it to, you know, a teenager and they're interested and they don't feel intimidated. So that's it. But yeah, but there's a bunch of us trying to work in policy. So connect with me, connect with the clinician scholars. We're all over the country. And sometimes it really helps to get some different people kind of with you, and you can develop a narrative with some stories and then push some stuff.
Thank you.
No, thank you. It's a good question. There's not enough of us in policy is the problem.
Yeah, and Tiffany, one way I also think is a great way to get engaged in policy is joining like national organizations. So like I'm part of Academy Health, and Academy Health is a great way to get involved. For example, when there's requests for information from different institutes within the NIH, sometimes we actually respond to those, which have kind of taught me how to write for policy a little bit more. So that's just one example. I mean, I'm in the end of my pre-doc right now, finishing up my dissertation, but it was a nice way to get some exposure.
Okay, thank you. It's a great
story.
I appreciate it.
Now it's weird because you have to be able to do the white papers, right? But you also have to have a 3-minute elevator speech. And it's, I don't know, it's tough.
Well, this was great. I think, you know, this extra time here has been so valuable, and I appreciate you making the time for it. I think it's a sign of just the interest in your presentation and how you were able to engage everyone today. So thank you once again, Adrienne, and please say hello to Dr. Kristen Choi.
Oh my gosh, you know, she's my main mentor right now.
Is she?
The woman is amazing.
Yes, I was happy to see her name pop up on the screen, and I was at another site. I came through Penn, but she's also a Hillman Scholar and still very involved with the Hillman Foundation. So,
and 40 under 40 in healthcare.
Yes.
But this is a small world. So feel free to reach out anybody, and I'll definitely kind of contact you back, because if we can all link arms, you know, we raise the tide a lot quicker, I think, if we all kind of come up together. But my pleasure. Thank you so much for having me.
Thank you so much.
Thank you.
Bye.
Thanks everyone for joining, and you can find this recording on the Hub website.